Hello, everybody, and thanks for joining us for this month's gathering of the Northern Virginia Health Policy Forum. I'm John Voorhees. I'm Senior Vice President at Applied Policy. We're a healthcare consulting firm in the Alexandria, Virginia area, Alexandria, DC. We're outside of DC. At Applied Policy, we focus on helping healthcare providers navigate through the world of healthcare policy. And we host these gatherings as an opportunity to promote an exchange of ideas and new approaches to the multiple issues and challenges that confront healthcare today. Today's forum, we're going to look at some new approaches or new thoughts about hospice care and palliative care. Our panelists, who are very well versed in this particular area of healthcare, will share some of their thoughts on ideas and new approaches to help prevent a decline in Medicare or Medicaid beneficiaries' health, and do so before it becomes a crisis or a terminal state. As probably we are all well aware, many people use our 911 emergency system as a means of treatment for chronic conditions. Clearly, our emergency system is not well set up to manage this kind of situation, and it puts a huge financial burden on all of the healthcare system, and it doesn't really address the long-term needs of the patients. So some of these ideas are things that we can maybe implement long-term and have a beneficial effect on all of the Medicare and Medicaid systems. Our guests today include Ido Banik. Ido is formerly a CEO of the National Hospice and Palliative Care Organization, as well as he was at the Centers for Medicare and Medicaid Services when several of my colleagues and I were also there. Ido has worked as a consumer advocate, a nonprofit leader, government policymaker, a trade association CEO, but throughout all of that work, he has worked to assure equity, accessibility, and quality of Medicare and Medicaid services. We're also joined by Tanya Saffer, who is currently at CMS. Tanya is the Division Director of Healthcare Payment Models in CMS's Innovation Center. Prior to her government service, she served in leadership roles at Onset Medical, as well as the National Kidney Foundation. We also have Kathy Hamill, who for the past 15 years has been president at Gilchrist Hospice, Maryland's largest hospice and serious illness end-of-life service provider. Gilchrist serves more than 25,000 patients annually, including seriously ill geriatric patients in multiple care settings. So throughout the webinar, we would love to have your questions. So feel free at the lower end of at the bottom of your screen, you should have a Q&A chat box. And in there, feel free to type in any questions you have. And towards the end of our session, we'll work to answer some of those. So for the moment, I'd like to offer an opportunity for the panelists to just a little bit further introduce themselves and maybe offer some initial thoughts about both palliative and hospice care. And Ido, I think I'd like to start with you if you'd do that.
Absolutely. Thank you, John, and thank you to the panelists and to the participants. What I want to reflect upon as I sit here now is what we've lived through collectively as a country. And one of the things that we've lived through, unfortunately, is a serious illness. And when those things happen, just as HIV and AIDS happened in the 80s and various other moments in time, I think it's really important that we reflect upon the system that we have in place, Medicare, Medicaid, commercial insurance, and the needs of the population, and continually update the system to make sure that it meets the needs of the population. One of my takeaways from what we've kind of lived here through collectively, and at the time I was at the National Hospice and Palliative Care Organization, before that I was in government, as you noted, is that you had a lot of people who were seriously ill, and the best option that we had for them to get care was to decline, to end up in the institution, and to get care in that institution and hopefully make it out and wait for the post-acute and the hospice care that all comes after you end up getting broken and you get put together. And so what I want to posit today, and what we'll talk about today, is whether palliative care, which is this interdisciplinary, community-based model, can actually serve both a pre-acute and a post-acute need, and whether it can both prevent individuals getting sicker and prevent individuals who are sick from having to go into the hospital to get care. In the name of equity and in the name of providing people with the care that they need, I think we have a lot to learn from both the last 2 years and also the various demonstrations that CMS has put together. So today, I'm coming to you with having led NHPCO and having served in government, but I can say whatever I want because I'm just Ido Banik, and so I'll try to bring that to today's conversation. Thank you.
Thanks, Ido. And that, having been a past Fed, I understand the release of being able to say exactly what you want to say as opposed to what you have to say. So with that, Kathy, could you introduce yourself and offer any initial thoughts?
Good morning, and thank you. I'm delighted to be here on the panel. I have the privilege of working every day with people who ultimately find their way to palliative and to hospice care. And I guess part of what I'd like to communicate today and what I hope we will take on as a nation is the single biggest complaint we get routinely is, I wish I knew about you sooner. And for people who are suffering from chronic illnesses and then advancing to hospice care, it continues to be such a misunderstood and an underplanned benefit. And I just can't stress enough the importance as we go through, as we approach this aging tsunami, what a wonderful opportunity it is to help communicate the benefits of both of these services. So I'm delighted to be here. Thank you.
Thanks, Kathy. Tanya.
I guess that leaves me as the actual Fed now.
Exactly.
So, I thank you both, John and Ido, for inviting me to participate and share my perspective and more importantly, that of the Innovation Center and the great work that the Innovation Center has been doing across the board to provide earlier coordinated care to Medicare beneficiaries, both in the primary care setting as well as when they have a chronic health condition or serious illness. I joined from the private sector, so I did have previous freedom to speak my mind and say whatever I want. Nobody has muzzled me here today for sure, but I'll have to stay within the confines of what I know to be true and what's publicly available. Just to give you a little bit of an overview of what the Innovation Center does is we do really test value-based payment models. And that's really our statute authority comes to, we want to improve quality of care at a lower cost. Ideally do both of those things, but we are mandated to at least do one of them without increasing healthcare costs. So if we're going to improve quality, we have to keep costs neutral. If we're going to lower healthcare costs, we also have to keep quality neutral. But I think everybody can understand that the goal is to do both, improve quality and lower healthcare costs. And so that's where what we are defined to do and sort of the confines of what I'll be able to represent today in my role. Thank you.
That's fantastic. Thanks so much. And again, thank you all for being here today. So what I'd like to do is start off, and Tanya, I'm going to start with you. Just to sort of level set with the audience, the hospice benefit in the current hospice benefit in Medicare is different than some of the other sort of better known benefits. Could you just give us a 10,000 or 20,000 foot view of the benefit, maybe some of the major distinctions between it and other benefits in Medicare?
Sure. So the hospice benefit is provided to Medicare beneficiaries who are certified to be at the end of life. So within that last 6 months of end of life, and that has to be certified by a clinician. And when they enter the hospice benefit, they receive a number of, I know we're going to talk about palliative care, but a number of palliative care services as well as other support services to help ease pain and suffering at the end of life and to reduce caregiver burden as well, because it's often, a very trying time for the beneficiary as well as the family that's supporting them at home. That benefit is provided in 90-day increments, but you never have to reapply for it. It just has to be recertified. And so it's continuous with no time limit on it once you enter the program. What you do have to, how it is different and what you do have to realize is that it is designed for end-of-life care. And therefore the expectation and the requirement is that you wouldn't be receiving other treatments or curative services, though you would still have access to clinicians and a care team to ease that end-of-life transition.
Great, thank you. And that certainly poses one of the big challenges for hospice care, that choice that people have to make. And we're going to touch on some of that in a little bit. But so Ido, in your previous life at NHPCO, I know you testified in front of the Ways and Means Committee, and you were advocating for a more expansive approach to palliative care, and also changing or adding to the Medicare hospice benefit. What does that really look like? And what does expanded palliative care do, and to whom does it, affect most directly?
Okay. And I think that this is a really important point to sort of get at the outset. We talk a lot about palliative care in the community, but in reality, the only sort of defined palliative care benefit that exists within Medicare is in the context of the hospice benefit. Palliative care is broader than hospice. Hospice includes a form of palliative care, but what doesn't exist is the ability to receive palliative care in any organized way outside of the hospice benefit. There are various demos, various flexibilities for Medicare Advantage plans, ACOs, other folks. So first of all, I think it all starts with a unified definition of what palliative care means outside of the hospice benefit, a floor that would guide everybody who wants to provide that benefit and use those words. The other part of it is to allow individuals to receive this palliative care, which I generally define as interdisciplinary, generally community-based care, and absolutely not only for the patient but also for the family. The important piece here is that be allowed to be provided alongside any so-called curative care that exists within all of the rest of Medicare. So the point that I was trying to make, and this was in 2019 before the pandemic, is if we just had some of the tools that palliative care provides, if we provided an organized benefit and helped to provide those individuals who are declining slowly at home, folks with COPD, folks with dementia, if we provided some of the tools to help offset some of that decline, that would be a really valuable thing that would, I think, hit both of the things that Tanya said, reducing costs and increasing quality, so that you wouldn't have to decline, fall down the stairs, go into acute care in order to get that care on the back end. So what I was advocating for there was a pre-acute benefit that would give CMS, that would give Medicare the tools to both offset declines, and once the declines happened, to provide serious illness care in the community without the individual having to choose hospice care and say, I don't want the curative care over there as well. Also, and we'll get to this later, we need to reform the hospice benefit. So there are really two things. One is a palliative care benefit that stands on its own. And the other thing is, how does that connect to a revised palliative care benefit? We'll get into that as we keep talking.
Thanks. Kathy or Tanya, anything to add to that?
Just one thing I would add is, I think, what you're talking about is defining a set of palliative care services, whereas we do have a definition in the federal code that I think you're probably familiar with, but in case the audience isn't, we'll just kind of share at a very high level. But really the Federal Code of Regulations defines palliative care as patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering, and that it involves addressing physical and intellectual, emotional, social, and spiritual needs, and facilitating patient autonomy, access to information, and choice. And I think that choice word is is very critical when we think about hospice, when we think about end of life, and then when we think about what are the services that a beneficiary and their family would most benefit from at a time and a trajectory in the illness that makes the most sense for deriving value out of that for the beneficiary. So palliative care is, as you said, provided throughout the continuum of illness, whereas hospice, as I mentioned earlier, is a specific Medicare covered benefit with defined parameters and provided at the end of life. I will just say, within our innovation center, as you pointed out, too, their palliative care is provided within the hospice benefit, but also provided, there are services provided that are palliative care related across many of our models. We can talk a little bit more about that in this session if people have questions, but certainly recognize that it is a benefit that beneficiaries may benefit from at different points in their illness.
Great. Kathy, anything?
And I would just like to add, sure, John. I think what I heard in the description, Tanya, and I just want to reinforce it because I think Ido started with it, is the need for multiple types of providers to be involved in palliative care. And today's compensation really only addresses provider-based reimbursement. And, unless you are enrolled in hospice. And so that's just one of the gaps that I think we face every day.
Follow on to that, Kathy, and maybe you've answered this already, but obviously you're on the front lines as a provider. Are there other practical challenges involved in expanding palliative and hospice care from your perspective?
Yeah, I think, and I believe that the hospice industry has done a great job in trying to respond to the service gap that exists within palliative care and the lack of a standardized benefit that really addresses those needs. But in spite of that, I think the challenges are very real. And most hospice organizations now operate both inpatient and community-based palliative care programs. But the biggest challenge is the lack of adequate reimbursement, in my mind, for the work. One of the biggest challenges. We're compensated primarily under, providers are compensated under Part B. Yet there are many models that would suggest that nurse and social worker-led palliative care programs are equally effective, yet there's no compensation for that. And that's probably even a lower cost model than a provider-based model. Secondly, I think we face some staffing challenges. We're not graduating or enrolling palliative care providers. So if the benefit is going to continue to support a provider-based model, we have to find a way to engage more people in the work and train them adequately for the work that they need to do. And then the third challenge, as I see it, is just the lack of adequate consumer and provider education and incentives to really access this service. I think we have kind of an image issue with getting seriously ill and then dying in general. We underplan, we underdiscuss, and I think having a national policy about just the importance of people talking about it and trying to normalize death and dying is also a significant challenge for us.
It's great. Ido and Tanya, any add-ons to that? One of the things that occurs to me out of all this is that, there's, and you sort of touched on this, Kathy, but the lack of sort of education about the palliative and hospice benefit, and before people get into a serious decline, how do we go about doing that? How do we get that out front and maybe change that sort of image issue?
Well, one thing I'd say is that you've heard it here, right? I said, well, there's really no palliative care benefit, and Tanya appropriately said, well, there's a definition of palliative care, and Kathy said, and that includes payment for certain kinds of clinicians and not for others, and all that's true. And so I think, to me, before we get to the image point, we need to get to the definition and the reimbursement point, because I think that we've been having this circular conversation in this country for 30, 40 years, where we say palliative care and people say, is that hospice? And we say, well, not exactly. The issue really is that it is kind of muddled. And it is the role of the government to demonstrate and to try kind of various approaches. But I think we're at the point now where we just have to provide more clarity. Now, once we provide that clarity, then we educate the public about the options that are available to them. But going back to COVID, it's a perfect example, right? You had a lot of people in the community who were seriously ill, who had underlying conditions. And we were fairly caught flat-footed as a country as to what it was that we could offer that population ahead of their decline. Hence the point, because I think we're talking both about systems change and we're talking about education. And my perspective is, let's start with the systems change. Let's start with actually providing a comprehensive bundle of services and reimbursement for those services. And let's then educate folks, because right now you have palliative medicine, which occurs mostly in institutional settings. You have palliative care, which is sort of muddled out in the community. And then you have palliative care within hospice. And I think we've got a lot of very confused folks out there. And I don't know that all the education in the world is going to unconfuse them unless we have some systems change.
Helpful. Thank you. Tanya, anything to add to any of that?
Yeah, happy to build on. I mean, I agree with Ido that there needs to be, or there's missing sort of this lack of clarity in what we talk about when we mean palliative care. We have a great federal definition, and I think that everybody agrees with that constitute what palliative care is, but there are not comprehensive services that are necessarily paid for prior to that. And I think where we have the biggest challenge, when you were talking about challenges, is we recognize that right now when you talk about end of life care, oftentimes when even though they have the choice of hospice care, that choice is really not chosen until like the last few days of life. So even when educated, we saw with one of the models that we ran, that we can talk about, our Medicare Choices model, that even when educated on the hospice benefit, beneficiaries did not choose it largely. And I think that's unfortunate, because the suffering could have been avoided or eased with earlier adoption. So I think really the challenge is identifying the beneficiary or the patient population most likely to benefit from increased access to palliative care outside of just hospice, as well as defining what high value palliative care is from the perspective of the beneficiaries and caregivers. Those are the most difficult challenges to tackle from my perspective. And then when we talk about education, I think it's really education at the right time in the Medicare beneficiaries' life, to be able to hear, receive, process, and make decisions about the care that they want to receive. And sometimes that it often happens in the face of illness, and when you've got a lot thrown at you, that can be very challenging. But too early can also be a challenge if that's just not something somebody's thinking about. If you're feeling great and healthy and out there living your best life, you're not necessarily going to think about, okay, what sort of palliative care services would I most benefit from once I'm sick? Those are three big challenges, I think.
Yeah. Thank you. No, that's really, it's insightful. We're not, I don't know if it's Americans or humans in general, but we're not, we don't like to say give up. And so it's a big step to say, yes, we'll move into a hospice benefit when I have to then give up all the curative aspect of it. But that's great. Thank you for that. So Ido, we talk about expanding the benefits. We've talked a little bit about what that might look like. That's clearly going to require some additional CMS oversight, and I'd love to hear a little bit from you about what you think that looks like.
Absolutely. And I think it's really important to sort of state it right at the beginning. I think part of this conversation has to do with the integrity of the benefits that are provided. So if you sort of accept the premise that right now there's a lot of stuff that's being provided that's called palliative care, and that some of that sort of is within the definition of what we've been talking about, and some of that is not, then part of the oversight has to do with, okay, where's the line? And are you north of that line or are you south of that line? And if you're south of that line, do you get to use that word? Right now, I think we have a lot of folks, especially in the private space, kind of crowing about the provision of palliative care all over the place. And it's really confusing for consumers to compare apples with oranges. So I think first of all, when we're talking about palliative care, the reason why we have to provide more clarity is because without clarity, there isn't sort of appropriate oversight, number one. Number two, in terms of hospice itself, I think obviously there's been a lot of scrutiny, and appropriately lately, about the provision of hospice care. And it's really important that CMS exercise, and the other parts of CMS, from the part that Tanya works in, exercise appropriate oversight over the hospice benefit to make sure that folks are meeting the conditions of participation and meeting the standards that have been set. And then importantly, meeting quality standards, some of which haven't yet been determined, to make sure that they're excellent providers. And I want to call out, my former colleagues, some of whom are on the phone at the National Hospice and Palliative Care Association, who have set up a quality initiative to at least try to sort of breach that gap between what exists and what should exist. So oversight of hospice, absolutely, it's crucial. But I would also say oversight of that more amorphous palliative care term, which, although defined, is not all that's being provided out there right now in the private market. And there is a gap between the CMS definition and what's actually provided. I would also say this is not only a federal issue, it's also a state issue. It's a state licensure of the services issue. There are various state limitations and practices, and Kathy knows, practicing in Maryland, there may be a certificate of need that impacts whether or not you could provide hospice services somewhere, but there may not be a certificate of need that impacts whether or not you could provide palliative care somewhere. Sometimes palliative care is licensed as home care. Sometimes it's licensed as hospice care. Sometimes it's not licensed at all. So all of that, I think, needs to be brought up to date if we're going to provide a more comprehensive benefit. And I would argue that we should.
No, that's great. And I want to get us into the Medicare Care Choices model, but before I do, it's Kathy, I wanted to ask you to maybe expand on this. In our work at Applied Policy, asking for additional regulation and oversight and whatnot. It's not something we do a lot of, with our work with providers. But do you have a thought about the oversight piece of it?
I'm one hospice provider, but we welcome the oversight. We have chosen for, what we call palliative care, our version of it, which is both inpatient and community-based. We chose to be accredited because we look for ways to make sure that we're providing care in the best way possible. So we welcome the oversight. We welcome the participation. We're going to pivot to this shortly, but we chose to participate with MCCM. So, ultimately we're here to solve a problem, which is to take better care of people.
Right.
And I don't think regulations are usually intended to make things worse. I think their intent is positive, and as I say, we welcome that oversight and participation.
Thank you. So let's jump into the Medicare Care Choices model. So I think between 2016 and the end of 2021, Medicare ran the MCCM. And so I'm going to turn to Tanya and ask her just to, again, give us sort of a high level view of what that was and maybe what lessons learned there came from it.
Sure, happy to. So the MCCM model, the Medicare Choices model, was a build on the hospice benefit, I guess is the succinct way to describe it. And what we were looking to do is to really allow for concurrent treatment curative care in specific populations while also providing palliative care services. So something that's not available within the hospice benefit that I mentioned earlier in my remarks. And we saw, as a result of that model, like, as I had mentioned, when provided with the choice or provided with the opportunity to receive palliative care services without entering hospice, most people did not want to enter into the hospice benefit, but we were able to have people adopt palliative care services, showing that did have some value to beneficiaries that were offered these services. We also saw a big increase in quality of life among those beneficiaries that did receive the palliative care services. And we did see somewhat of an increase in hospice utilization earlier on, before death, in the population that was receiving services under MCCM. And we also saw cost reduction with the model as a result too. So it did actually achieve the improved quality and the reduction in cost that we are seeking. What we are looking to do now is actually build upon that model and really take the lessons learned and, see how we can apply them across other demonstrations that we are working on. And, I can just, I'm happy to share a little bit more about what we're thinking there, but I'll stop there and let others chime in.
Thank you. Yeah, Kathy, as you mentioned, you were a participant in the MCCM. What was Gilchrist's experience with it?
Yeah, we participated because we really believed that the concurrent approach to care is really important with some diagnoses. We kind of see the world in three categories. There are people that we call warriors, and they are people who are going to seek active treatment until the moment that they take their last breath. There are what we call early adapters. Those are people who are very clear that they are going to move to a palliative and hospice treatment option early and often, and they're very clear about that. But the majority of us are what we call negotiators. And we want to understand, if we make this choice, what's going to happen, and if we make this choice, what's going to happen. And we play in kind of that risk band and negotiation, which is why palliative care conversations are so important to have on an ongoing basis, because I pivot as I feel differently during my process. But if you think about negotiators, having to make a hard stop, with today I'm curative, tomorrow I'm not, it's almost impossible. Our kids program is a great example. We are blessed in the state of Maryland to be able to provide concurrent care for children. You can imagine that a family making a decision that they are going to move to hospice and never, ever consider a treatment for their child is virtually impossible. And it works very effectively. We believe that the notion of hope and cope is concurrent. Today's model is what we call gloom and doom. You have one choice and one choice only, and that's to abruptly start treatment. The MCCM model for people like leukemics was critical, because having blood transfusions throughout the way actually makes you feel better. And so not having to make these hard stops was critical. For us personally, we enrolled close to 1,000 people over the 5 years. We embedded the MCCM patients with our traditional hospice patients, and over 80% of them converted to hospice. And the 20% that don't are really in that warrior category, and they probably never will. But it doesn't mean that we don't reduce utilization. Our savings in the MCCM program was estimated to be $14,000 a beneficiary in a 12-month period. So they were substantial savings. And we had people so sad when the benefit ended. We still had some people on service. Our response to that was to build a geriatric primary care practice that allows people to receive services from a hospice organization without being enrolled directly in hospice. But we are remaining optimistic that Tanya, CMS will continue to study this and come out with an expansion of the benefit that makes sense for the majority of Americans who fall in that negotiation category. Thank you.
Thanks, Kathy.
And John, I just want to add, this, obviously all the focus is on the administration and CMMI has this authority, but in some ways CMMI did what CMMI is supposed to do, which is CMMI ran a demo, CMMI got an outcome. And it's at least worth noting that one of the things that we may have learned from the MCCM demo was that one of the initial premises of the hospice benefit was, look, if you provide people options, that is options to have curative and palliative care at the same time, then spending is going to go up. Well, that's not true. MCCM shows what I think Kathy and her team already know, which is if you remove that horrible choice, more people will choose hospice earlier and spending actually goes down. And so it's at least worth considering whether the next step, in addition to sort of expanded work and demos at CMMI, is actually to say to Congress, which Congress isn't doing much these days, but to say to Congress, hey, how about updating the hospice Medicare benefit, because we've sort of learned that one of the original premises was incorrect. And CMMI was set up not just to keep doing demos, but actually to inform changes that we make to the system at large. And that is, it's at least worth thinking about whether that's a possible outcome of this. And I would argue it would be a good one.
I might also add that our commercial carriers do allow for these compassionate care or concurrent care benefits. And I'm not sure that age makes you any more comfortable with decisions around treatment. And so in the commercial population, part of the premise is that I'm younger and so it's harder. And again, I'm not sure that our lived experience is that people get more comfortable with that decision, the later in life. The notion that we've lived a good life and I don't really want another day happens less often than I think we might believe.
Yeah, no, that's great. Thank you. So I want to get to some audience questions because the folks are starting to chime in. But before I do that, we can't get off the conversation without talking about money, right? So, during your testimony, I know that you were asked specifically about cost of these changes and sort of the resource requirements to do some of the things that you're talking about. Can you just spend a moment or two talking about that?
Yeah, I think, there was some interesting exchanges in that testimony about trade-offs. So, I think I was asked the question, well, if we provide all these benefits, then what's going to have to give? And I think the feedback I gave then, I think what I'd still say now is actually the status quo is more expensive. Requiring people to decline, get broken, and then get help in the institution, and only to then come out and get nursing home care, home health care, and then hospice care. Is potentially more expensive than actually what we're talking about, which is one, provide more community-based care so that we're offsetting some declines. That'll save Medicaid money. And provide Medicare with more tools to provide this really comprehensive, more expansive palliative care benefit, where you're not actually just talking about the medical part of it, but you're also talking about the social workers, you're talking about the chaplains, you're talking about more volunteerism. You're really talking about utilizing a lot of the lessons that we've learned from the hospice benefit. So the trade-off is that if we provide more of that sort of palliative care, we will offset that and then some, as MCCM shows us, through reduced utilization and more expensive, more intensive care.
Great. Anything to add to that, folks?
I'm happy to add just a little bit there. I think, very much in alignment, this administration has touted more access to earlier community-based care to more home care, as we've seen as well, and to avoid exactly that trajectory that you're talking about, where we have these acute episodes followed by post-acute episodes, and then ultimately long-term institutionalized care as well. It's informing our thinking around how do we better care for dementia. It's informing our thinking on how do we, like I said, incorporate this into some of the other models that we run for people that are chronically ill, like the kidney care choices models that we're running. So all of those things are definitely at top of our mind, and we are very open and welcome to stakeholder input, particularly the experience of beneficiaries and caregivers, as we think through how do we think through a more broader set of services that can reduce these type of acute episodes and long-term care spending.
Thanks. So awesome. Thank you so much, you guys. So I've got a couple of good questions coming in from the audience here. So I'd like to do that, and I hope you all will forgive me for reading them. But the best I can do is to read them for you guys. So the first comes from a palliative care social worker, and Rebecca has asked. Rebecca says she's a palliative care social worker. She would like to know how palliative care can be more billable to generate income as that service grows. Anybody have a thought on that for Rebecca?
Well,
Rebecca, you stumped the panel.
Well, no, I'm going to call on Kathy, but I would just add or say that's sort of what we're talking about, where right now, in order to bill for most of what we call palliative care, you have to be a physician, a physician's assistant, or a nurse practitioner, and all that other stuff. The nurse, the social worker, the chaplain, all that other stuff is kind of not billable. And absolutely, what we've learned from the hospice benefit is that true interdisciplinary care requires all those disciplines being at the table and billable as well.
And we recognize, and Rebecca, thank you for your work in palliative care. It's so important. And I think advanced care planning and the structuring of those conversations, your background as a social worker is tailor-made for those conversations. And so we'd like to see that compensation. We understand that there might be a bill pending out there for compensation for advanced care planning for social workers. So Rebecca, you have my vote. So, and we'll continue to monitor that compensation, but couldn't agree with you more.
Thank you. That's great. So let's see here. I've got a question from one of Applied Policy's own here. Kate Clausen is based in Europe, and so she asks that I frequently see private homes here that have a separate part of the home with maybe 2 or 3 bedrooms, and they think of it as almost home. Is this a model for hospice? This is hospice care there, but is this a model that Medicare and other payers might be able to consider or emulate? Is there anything like that makes sense for us?
Well, I would say there is already, just in terms of the hospice. And remember, the hospice benefit started in the UK and then came over here, but this country still probably has the most robust hospice benefit in the world, with some severe limitations. But there is, as Kathy noted earlier, some hospices have inpatient units. Some hospices provide hospice care in hospitals. Some provide inpatient care in nursing facilities and also at home. So there are different settings right now where the hospice benefit will sort of provide that care. But I wonder, Kathy, if you have anything to add, or maybe some unique approaches.
Yeah, I think our facility-based care, and thanks for the question, especially at the residential level of care, and I'm using, regulatory language. We do operate an 18-bed residential unit. The challenge is that the room and board is not compensated. And so for families who don't have the ability to pay for that care in a group home or in a facility of sorts, there's really no mechanism. We are providing those services through philanthropy. But again, we believe that moving forward, there are hospice patients who are sitting in skilled nursing beds because skilled nursing beds are paid for, where long-term care beds are not. And so that's, in my opinion, a huge missed opportunity to move people to the right level of care sooner. But we have this barrier of not being able to afford room and board. And if you don't have a home, City of Baltimore is a great example, or you don't have a home-based caregiver who can take care of you. We find people in facilities and settings that are beyond what they need, which is a missed opportunity for everybody and financially inappropriate.
And that's why, in a sense, this conversation is deeper than just a conversation about hospice and palliative care, because in other countries do a better job of providing for long-term care, of providing for housing, of providing for food, of providing for transportation. And so you have this entire infrastructure sort of built around what it means to be aging in many other places. And so in our country, although we've got this pretty robust hospice benefit, individuals still have to pay out of pocket for their housing. They still have to pay out of pocket for personal care services. And so some of those supports that surround that don't exist here. And this is a much bigger conversation, therefore, than just hospice and palliative care. We're also talking about our lack of a long-term care system.
Thank you, you guys. And so there are lots of other questions here, but I do want to give our panelists an opportunity to provide a last thought here. So to the audience, we will do our best to post some answers to some of the questions that you guys have put up that we didn't get to here. But thank you so much there are some great questions, and I'm sure that there'll be some thoughts that we can provide. So we've got about 6 minutes, on our time clock at the moment. I'd love to sort of walk around through each of you and just ask for your closing thought about this and the takeaways maybe that you got from our discussion today. So Tanya, I'm going to start with you this time.
I'm actually I can see the questions, and there's actually one in here that I do want to address in kind of my closing remarks. I don't have an answer for it, but I want to call it out because I think it really is important, because we spent a lot of time talking about Medicare and Medicare program and cost and reimbursement. And Luana Boykins asks, healthcare is complex even when a patient is not ill. How do we, and she references all markets of healthcare, integrate compassionate care as a normal part of the model and not just an extra service that can be seen as cost savings? So I think that's a really good question too. I recognize not all services can be provided without reimbursement, but I think there are other things we need to think about when we about how we interact with beneficiaries and people that are ill, or just those that are seeking out preventative care services or in need of those services. So I thought that was really important to call attention to, and appreciate the question. And then I just want to thank all of the panelists here. This has been a really great discussion. I've learned a lot from everybody's comments, and love to continue the conversation with you all, as well as the people in the audience. So feel free to reach out to me if you have any ideas and solutions to these challenges. We are definitely thinking about it at CMMI, what our next steps are, how do we apply these lessons learned. And I want to say I'm one person relatively new to CMMI, not new to health policy, not new to end-of-life care, but new to CMMI. And there's an entire team within my division that I just wanted to thank them for their support, my peers across divisions for their support in this conversation, as well as my leadership for providing their thoughts and experiences as they've worked on end-of-life and palliative care issues. So thank you.
Great, thank you so much, Tanya. Kathy?
Yeah, thank you. This is, for me, this has been invaluable. As a provider, we don't always have the opportunity to stop and really think about what the policy implications are and how we might make more systemic changes. We do, more firefighting on a day-to-day basis. So I've really enjoyed having the opportunity to think about it and obviously to meet others on the panel and have this very rich dialogue. I guess what I'm struck by is that this work needs to be normalized throughout our lives. We treat end-of-life care as if it's like a segment of our lives. And, there are sudden deaths every day, and people underplan and under-discuss that work. And I would just invite us to think about how we normalize it throughout someone's life. And Tanya, I am really looking forward to more dialogue with you. I would like to spend some time with you, and because we're close by, maybe you'll come and visit. So thank you.
Love it when we can connect people. This is great. It doesn't usually happen between the panelists, but that's wonderful. Ido, final thoughts for us.
First of all, thank you, John, and this forum. Thank you, Tanya, for your service and for being here, and Kathy, thank you for the service and for all the folks that are on as attendees who provide this great care. My takeaway is that as Kathy said, the reality is that we never do know when the end of life is, and we don't know when we're going to be struck by serious illness. COVID showed that to all of us. Very few people thought that we'd ever be in this position over the last 2 years. I want to think about the silver lining of this horrible moment that we've lived through as a country, being how we can better plan for serious illness and how we can then make some changes in our system to make sure that we're not caught flat-footed the next time we have a pandemic or the next time that we have something unexpected come up. And we do know that unexpected things come up all the time. And I'm committed, I know that Kathy and Tanya are as well, to making sure that we continue to evolve and improve our healthcare system. And again, thank you so much for having me on.
That's fantastic. Thank you. You guys were a terrific panel. This has been really fun for us to have this chat. So just for the audience, just 2 little headlines I'd like to give you. Applied Policy does have a newsletter, the Applied Policy Insight. And I think in the chat box, you'll see the link, but we'll also, when we send out follow-up materials for this session, we'll include the information there. So please sign up and get our monthly newsletter. And then lastly, the next Northern Virginia Health Policy Forum will be February 15. We've got a panel of 3 reporters, healthcare reporters. They're going to be on the panel. And as you might imagine, they have very, very interesting insights into what's going on in healthcare. And they're going to opine a little bit on what they think is going to happen over the course of 2023. So I think that's going to be a super exciting one too. So I hope you'll join us. And with that, right at 1 o'clock, how about that? The syrup and the pancakes came out perfectly. So thank you all. We really appreciate the time. And panelists, thank you guys. This has been fantastic. Have a great day, y'all.